Before we even talk about mechanical ventilation in general, we need to quickly review the physiology of breathing spontaneously and then what happens when you intubate somebody, because this slide right here is very important to understand. Whenever we talk about changing a ventilator mode or increasing a setting, it's going to affect what we're fixing to speak of right now. Just for review, remember that when we breathe in, and we take a deep breath in now when we're breathing spontaneously, the act of breathing requires that we contract our diaphragms, our diaphragm drops out, and then our rib cage rises. And then when that happens, what happens to the pressure inside the lung? If this drops and this expands, what happens to the pressure inside the lung? It decreases. So we simply invite air into our lungs at that point. So we create a negative pressure and invite airflow into our lungs at that point. And that's key to know because whenever you invite air into your lungs, not only are you inviting air into your thoracic cavity, but you're also increasing venous return. People forget that. And for example, if I were to take a deep breath right now, when I did that first sudden inspiratory effort I did, I actually invited more blood flow back to my heart at that point. So spontaneously breathing always maximizes your venous return. And you and I both know that if you increase venous return, you have better stroke volume, therefore you're going to maximize your cardiac output. So we need to remember that we knock that drive out whenever we paralyze and sedate patients. So not only do you invite air into your chest, but you invite venous return back to your heart whenever you're spontaneously breathing. And you and I, when you're sitting here breathing, you two are breathing anywhere from 3 to 7 cc's per kilo of ideal body weight, not weight, of ideal body weight. Now you'll occasionally sigh as well. So you might think, oh, 3 is kind of low. Well, it is, but occasionally you will sigh to recruit, or you'll yawn or something like that. So keep that in mind. That's the size tidal volume that you breathe right now. And don't forget that when you're breathing right now, you're maximizing venous return and you're not compromising any cardiac output at this point when you're spontaneously breathing. However, now we're going to intubate you. Dr. Whitlock, we're going to intubate you, so we paralyze and sedate you. And when we do that, now we're just pushing air into your lungs. Don't you agree? We're just throwing it in there. Now when we do that, how do we know that we're giving you an adequate tidal volume? Let's say you're at the bedside with a patient and you have an ambu bag on them. How do you dictate that you're giving them an adequate tidal volume? What do you look at? Good. You look at chest rise. You squeeze the bag and you see chest rise. So you're telling me that if I walk up to the bedside and you're on a ventilator and I see your chest rise and fall, that I have to understand this is what's happening. I'm inflating this lung to the point that I'm taking soft tissue of the lung and expanding it enough that I'm actually displacing a skeletal structure. When you agree, we're pushing the rib cage out. Not only are we doing that, but we look at x-ray too to make sure we're giving you a nice breath. We look to make sure that we have diaphragm excursion pretty fair. We want to look around, usually around T8 to 9, is where you want to look at on x-ray for your diaphragm. So we agree that we are giving this patient enough positive pressure that we're making the chest rise and displacing the diaphragm, right? Now, here's what we forget to think about. We're pushing this pressure out, down on the diaphragm, but unfortunately, what structure are we also pushing inward on? The heart. So that's a strike against us as soon as you intubate somebody, assuming they're paralyzed. You are pushing just as much pressure on the mediastinum and the heart as you are to make the rib cage rise. So a lot of times, if your patient has poor vasomotor tone or they have very little reserve or blood pressure issues, you're going to come into a problem, because if you give this patient a large enough pressure or a high enough tidal volume, what do you think you might be doing to venous return at that point? You're going to be dropping it. I always tell people, if you think of a patient intubated, when I see them laying on the bed, I take an imaginary rubber band and wrap around their neck and their waist, and I say, you know what? Because that's what's happening. If I'm putting positive pressure in your chest, then I'm discouraging any venous return from the lower part of the body or the upper part of the body to the point that I can impair cardiac output. Now, you're pretty healthy, so if I intubate you, don't think your blood pressure is going to drop out and your cardiac output goes to the floor. You do have decent vasomotor tone and all that, but I'm talking about the critically ill patient who already needs some sort of vasopressor to maintain that. So keep that in mind. When you intubate a patient, you're knocking out that thoracic pump mechanism I was talking about earlier that increases that venous return. And when we intubate you, we do ventilate you at a little bit higher tidal volume rate. You notice that we have you anywhere from 8 to 10 cc's per kilo of ideal body weight. And the reason it's a little higher than you spontaneously breathing is we don't dial in a sigh at this point. It's coming back in literature, by the way, but we don't dial in a sigh. So we want to keep it a little bit higher tidal volume so we don't promote atelectasis. But Dr. Simpkins will tell you that he likes to hang out around that if possible because it keeps the pressures down. Once again, he's being sensitive to the fact that we don't want to compromise cardiac output to a large degree by putting too much pressure in the lung. So remember this slide from this point forward whenever I talk about, if you tell me, hey, we need to go up on this, or we're going to change the I time, or we're going to change something else. Anytime we change a ventilator setting, we want to reassess the patient's cardiac output, and not necessarily a venous return, but the cardiac output and their blood pressure. Does that make sense? Because when you paralyze somebody, you lose that. So I'm just going to tell you, if you have a trauma patient and they have a weak 30 pulse, and their cap refill is 5 seconds, and their blood pressure is questionably low, if you paralyze them, you're at risk of sending them to cardiovascular collapse, because their spontaneous efforts might be the only reason why they have a decent cardiac output right now. Instead, you might have a fluid bolus on standby when you intubate this patient, because I want you to think of that. You know, you can't separate the two. A lot of people say, oh, he's got a pulmonary problem, you know, let's intubate him and fix it. But you cannot separate the pulmonary problem from the cardiac issue, because you're going to embarrass cardiac function to a certain degree. So, slide 1. Anytime I talk about a vent change from here on out, remember, okay, we need to recheck and make sure that the patient's heart likes it. The simplest way to explain ventilator modes is to remind you that there's only 2 modes. You either have someone in a volume mode or someone's going to be in a pressure mode. And it's all about the way the breath is delivered. Volume modes would be volume control modes, like your volume control. We use a mode in SICU called SIMV volume control. And let's talk about the good and the bad real quick of volume control modes and the good and bad of pressure control modes. Volume control, well, the name itself tells you a good thing about it. What is a good thing about volume control? What's controlled? Volume, good. So I intubate Dr. Whitlock, and when I do, I set her tidal volume at 500 cc's, and I give her a rate of 10. Well, I tell the ventilator to give you 500 cc's. It's a volume control. If I come back 3 hours from now, what's your tidal volume still going to be? 500. I come back 3 days, what's your tidal volume going to be? 500. So what's a great thing about volume control? Tidal volume's the same, therefore minute volume's the same, so it's really nice. So that's a good thing about volume control. However, if volume is controlled and set steady, what can go up and down based on your lung compliance, unfortunately? The pressure. And that's what I'm drawing here. This pressure can go up or down. Let's pretend like this is 30. Well, you're doing fine with 30 of pressure right now. But because I told the ventilator to give you 500 cc's no matter what the cost, 3 hours I can come back and your peak pressure can be 60 without me knowing. And so that's a disadvantage. Now, gratefully and thankfully here we have a policy, so that our alarms are set, that it starts honking at us if you get a 10 above where we have you set to begin with. So we know that your peak pressures are getting high. And we want to stay at this hospital less than 30 on all our pressures on all our patients. There's literature out there showing that even at a 30 of pressure at the vent, that some of those airways, those small airways, are experiencing up to 120 centimeters of water pressure to open them up. So remember, 30 is average. That's what makes its way all the way back to the ventilator through the tubing. And so that's why we keep it 30 or less. And you'll see Simpkins at the bedside going, what's a plateau? You probably heard him say that. And he wants those plateaus 30 or less for that reason. So what's a disadvantage to volume control mode? I just listed it there.
So, if you have increased compliance, then you can't modify for the pressure.
Okay, if we have a change in compliance, our pressure is going to change. Exactly right. So that's a huge disadvantage. So disadvantage of any volume mode is the pressure is not controlled. Now, do you think you do fine on volume mode? If I intubated y'all, would y'all be fine on volume mode probably? Yeah. Y'all have healthy lungs, and we'll talk about that. You'll see that this flow waveform is the reason why you would do fine, but if you were sick, why you won't do fine. So pressure, do you understand it can go up and down based on the tidal volume I have set, okay? And so here's how flow is released from the ventilator on the same breath. Flow is released from the ventilator. If I had a ventilator sitting right here, I had the tubing, and it goes to the patient, what's the first thing, as soon as the breath is delivered, what's the first thing the flow has to fill before it even reaches the patient? What's between the vent and the patient has to fill up first? The tubing, good. So you're going to tell me that it fills up the tubing first, and I'm going to write circuit, not real nice handwriting here, but I'm going to write circuit and LAW for large airways. So that's the first thing it fills when it leaves the ventilator. And let's pretend like this is some most vents around 40 liters per minute is the flow that's coming out for this size breath. So 40 liters a minute, and look what it does. It stays the same speed. It launches out, it stays 40 liters per minute, then cycles off whenever the tidal volume is given. What is the functional unit of respiration that we're trying to reach at the very end of the breath that we're trying to open so gas exchange can occur? The alveoli, very good. She jumped on that quick. She must have just read that. But good. The alveoli. Our goal is to reach the alveolus at the end of the breath. And remember, 40 liters a minute, even in the smallest airways for me and you is fine. Because remember, your bronchial tree, it branches exponentially. So resistance actually drops. If you think about it, it branches smaller and smaller and smaller, but it branches so quickly that resistance goes down. But Dr. Whitlock forgot to tell me before surgery that she has a history of asthma. She forgot to tell me that she had a little cold, a little fever. So look at her airway. Down at her terminal airways before her alveoli, she actually has some lesions in her airway, be it mucus, inflammation. What do you think about 40 liters per minute trying to get through a tiny, tight airway that's diseased? What's going to be a problem with that? It's going to be high pressures. Very good. And that's exactly how we know that that is going on. When your peak pressures are climbing, that means we're seeing some resistance down here, maybe a disease process. And we'll typically see a higher pressure. You already mentioned that. So we'll have an increase in your PIPs. PIP stands for peak inspiratory pressures. So you'll have an increase in your peak pressures on your vent. What might be happening on your x-ray? If you see this happening, because you know you're going to hit that, is it going to get through it or is it going to turn around and go somewhere else? It's going to go somewhere else. And if you have healthy lung right here, where's it going to go? Yeah, bad news. Look what it's going to do. It's going to come over here to the healthy lung to the point that we might start overinflating that one. Y'all see that? That's how these lungs get sicker and sicker, for lack of better terms, by just us having them on a ventilator. And so it goes to healthy lung, and the lung that's salvageable, we cause an air leak on, and we never even pop that open because we have this flow that's down here subjecting that airway to a lot of trauma. So our peaks go up. So if this collapses, then you would assume that our x-ray it's going to go south on us, isn't it? And then obviously we lose diffusion, so what's our pulse ox usually doing at this point? It's going to hit the floor too. So I'm going to tell you that when the therapist calls you and says, hey, look, our x-ray's looking crappy, that's a technical term, isn't it? But our x-ray's looking crappy and our peaks are climbing, then you know that this is happening down the airway. You don't need an x-ray. You don't need x-ray vision. X-ray will help you, but you know that at that point that's happening. At that point, that's when a volume mode is not good for your patient. Peaks are higher than 30, 35. Your x-ray's getting worse. You can't increase their oxygenation by any other means. They are no longer a candidate for a volume mode. Now, why aren't they a good candidate for this volume mode anymore? How's this breath being delivered that is not gentle to the airways? How's it being delivered that's not gentle to the airways? What's that flow doing? Very good. The flow is very turbulent. It's forceful. See how it just shoots in, stays the same speed? So it's too much flow for this patient. And so at this point, that's when if Alan calls you and says, like the peaks are high, we need to do something. The therapist is usually you can open that. The therapist is usually at that point going to suggest to you that the therapist is usually going to suggest that we turn them over to a pressure control mode. And this is why. As soon as you flip the switch, on to a pressure control mode, look what happens to the way the flow is released from the ventilator. Do you see the shape of it? First off, it may start out a little faster, say 60. That's no big deal because y'all told me a minute ago, what does it feel right at first as soon as it's leaving the ventilator? Tubing, everything's the same. Tubing and large airways. So our large airways and tubing, it doesn't matter if that sees high flow, does it? But then look, you so astutely told me earlier that at the end of the inspiration or end of the breath, we're hopefully opening and reaching which functional unit of respiration? Alveoli, very good. So look at this. You don't have to be a Rhodes Scholar to figure this out, but if I'm trying to get 5 liters of flow in a small airway instead of 40, am I going to have better success getting 5 through there? I am. So what's going to happen to my peak pressures? They're going to go down. Does that make sense? Because I have less flow trying to cram into air. So as soon as you flip the switch, you're going to see that your peak pressures go down. That'll happen. That's a given. And you just told me a slower flow is going to have a better shot at getting through there. So is this atelectasis going to resolve possibly? It should. If we have a good PEEP and other settings, then it should. So we might recruit that back. And if we do that, pressure then can equilibrate. Does that make sense? If this is high pressure on this side it's going to kind of equilibrate and even out so that you have a better x-ray at that point. And you'll see this 9 times out of 10. You'll see it within the first 3 or 4 minutes. What's their SAT going to do if this begins to occur? It's going to go up. And you've touched nothing except the mode. You haven't touched FiO2. You haven't touched anything else, PEEP or anything. You just changed the mode. So an increase in saturation will occur. So what benefit did this flow give us over the volume shape, the volume flow characteristic? What does that do for us? It's better. It recruited, and why did it recruit when that couldn't?
Because it was giving the alveoli a chance to open up with a low flow.
Very good. The lower flow was able to reach the alveoli. So I like to teach people that this is called, if I put an equal sign out here, I like to teach people this is called gentle flow. Y'all with me on that? This is. Can you picture that in your mind? I mean, that's not a technical term, but this is so much gentler to the airway versus cramming 40 down there. But I don't want you to think this is all bad over here. This is great for healthy lungs. Matter of fact, you want to know. You want to open that again? You want to know that if you have a healthy lung individual, you want to know what their tidal volume is, and you want to know what their minute volume is. But when you flip that switch and this flow becomes decelerating, it's so much more gentle to the patient. And so, so keep that in mind. So not only does change into a pressure mode allow the flow to change shape and be gentle on the airway, but it allows you to control the pressure. For example, you can now set the pressure at 30. Alrighty? So if I walk out of your room, she's intubated by the way. I walk out of Dr. Whitlock's room and she's in pressure control. And so if I walk out and come back in 30 minutes, what's your pressure going to be? 30. If I walk out and come back in 3 hours, what's your pressure going to be? 30. 3 days, what's your pressure going to be? Alright, good. So pressure control means we're controlling the pressure. But unfortunately, if I come back in 3 hours, your pressure will be 30, but what now is going to be your variable? The tidal volume. So your tidal volume is going to be compromised even though your pressure is set. And so back in the day, we understood that, hey, pressure control is the way to go because we really love how gentle this decelerating flow pattern is on Dr. Whitlock's lungs. So we like that. We're saturating fine. But every 2 or 3 hours, we're having to tell the therapist to go in there and adjust that pressure so that we have a tidal volume around 500 because that's where you got a good CO2 on that patient. So y'all would write an order back in the day that way. You'd write adjust pressure level to get tidal volume 500. And every hour and a half, I'd walk by the ventilator and I'd go, man, the tidal volume's low. And I'd go up on the pressure. And then they got dialyzed, they got a diuretic or something, or diurese, and I walk back an hour and a half later and the tidal volume's 800. And I'm coming back down on the knob doing a whole vent check. And we got tired of that. But that at least showed us that we can control the pressure, but we couldn't control the volume. So we had to go up and down all the time. So so pressure control, the advantage is your pressure is truly controlled, but your volume is not. Your volume is your variable. And that's why Servo, which is the company of the ventilator y'all use, they came out with a mode that's very helpful to us. And they said, you know what? We're tired of the therapist having to go out of the room every time the doctor wants a tidal volume of X when they're in pressure control. So let's make a mode where we can set a tidal volume, say at 500, and we will tell the ventilator to go up and down on this pressure control level to get a tidal volume of 500. And it'll do it with this gentle decelerating flow pattern we just got through talking about. That's what PRVC is. It combines both. It lets you set a tidal volume, but it delivers it with these characteristics, not these. So PRVC is not a volume control mode as you would think it is. It is a pressure control mode, but it's regulated by the volume you set. Does that make sense? I'm still delivering it with these characteristics, but I'm still getting a targeted tidal volume at the same time. So that's what PRVC is. It's the best of both worlds. It's a volume guarantee with the benefits of pressure, such as the decelerating flow pattern that's very gentle. And Dr. Simpkins, we just got through talking about how gentle this flow, when it shoots in and decelerates down, at this slower flow is when you're down at the terminal airways. And so if you do have lesions and obstructions, this slower flow has a better chance of recruiting. And that's why your PIPs come down, because you have less flow in small airways and pressure control modes.
That's a very nice explanation.
And so that's the whole goal of pressure control, is that right there. But PRVC, tell me what's nice about it. What is PRVC good for? What's a nice thing about PRVC when you look at both sides of this chart?
Gives you a controlled volume,
Good, you
definite
get that?
volume with the gentle flow.
Very good. You get this over here off this side, but you get it delivered in this mechanism. And that's what makes it nice. That's why almost every patient, if their peak pressures are high in SI, if we do flip them over to PRVC, their peaks will come down if they're not fighting the vent. Because You're still got the same tidal volume set, but it's delivered with a lower flow and a decelerating flow, so that you have less resistance in the small airway, so your peaks come down every time. And that's what it does. So I like to call PRVC automatic pressure control, because it's automatic for me. I don't have to go I no longer have to go in the room and go up and down on the pressure control. The ventilator is doing that for me. And you can have your way with your tidal volume, and I can have my way with the most comfortable way to deliver the breath and the safest way to deliver the breath. And I just wanted to add this to show you that it's delivered with the decelerating flow pattern we just got through talking about, and a square pressure waveform. It still rises up to that pressure and holds it. And that's key, because if it pressurizes the lung instantly, it's going to pressurize and hold it. You truly get more of an average pressure in the lung, which is called the mean airway pressure. So another benefit of PRVC is you get a higher mean airway pressure with the same given tidal volume and a volume mode. So you get better mean, and you get less peak pressures because you have a gentler flow pattern. So that's PRVC. Why would we switch? So just in review, let's review that slide we just went over. Why would you think the therapist would call you to switch from a volume mode to a pressure mode? What would be their concern?
Get too high of pressure.
Good, too high of pressure, very good. What else might they see?
The X-ray was looking bad. And
Good.
a lot of collapse.
Good. A lot more atelectasis occurring and whatnot. If they're in volume mode, use that in combination with the peak pressures. We might suggest at that point that they might benefit from some sort of pressure mode. And in this institution, PRVC is the famous one that we like to go to. I just explained to you that PRVC gave you a volume guarantee, but it gave it with this gentle flow pattern and its automatic pressure control. Well, Siemens or Servo didn't want to stop with just PRVC. They said, you know what? Let's do it for a spontaneous breathing breath as well.
I have a question about
Yes, go ahead.
PRVC. You know, if you're giving it for high airway pressures or peak pressures and whatnot, and they're going to give you a certain tidal volume, and they're going to adjust the pressure to give you that, you know, how is that not going to, you know, increase your peak pressures?
Right. Your peaks will still go up and down. Don't let anybody tell you that you're controlling the pressure. You're not controlling the pressure
So the
anymore.
pressure's still going to...
It's still going to vary.
It's still going to vary.
It is.
According to what volume you
Exactly
want.
right. According to the last breath, too. But it's going to do it with less pressure than a volume breath because of this characteristic here. Yeah. Your pressures... Now, I can control the pressures in PRVC, but your tidal volume is going to be locked out. For example, I can take my pressure limit knob and put it right above what the peaks are, and I'll keep it there, but your volume will suffer. But it does go up and down, so it's truly not controlling your pressure, but it's called a pressure control mode because it's delivering it with the pressure control characteristics, i.e. the flow waveform and the pressure waveform.
Yeah.
So, but you're right, it still varies, but it's still going to be less than that if you were in a volume mode. Usually at least by 4 or 5 centimeters of water pressure. Yeah. And what's bad about PRVC is it says C, control. It's a control mode, meaning the patient has a set, the ventilator has a set I time and the tidal volume it's trying to get. So every time the patient initiates a breath, they can't get pressure support there. They're going to get an I time and a tidal volume of 500 or whatever's dialed in. So you might see them fight, and you'll see this. You'll see them doing the belly thing where they're pushing against it. So a disadvantage to PRVC is the fact that it is controlled. So your patient needs to be sedated. Not necessarily paralyzed, but they do need to be heavily sedated, or they'll wake up and start fighting this mode. And if they do fight it, we call fighting it, then we do transfer them over to a mode called volume support. And I'll show you why this mode works in conjunction with this. Volume support still gives them a guarantee of 500 cc's if you have that dialed in. But it does it by automatically adjusting the pressure support level. You know, pressure support is a mode where if I just dial in 10 of pressure and 5 of peak, well, the ventilator is going to go to a pressure of 15 every time. It's going to go to a total of 15 pressure. And if your patient gets tired, their tidal volume is going to drop because the ventilator is just giving your patient a set pressure. And it doesn't give an I time or anything else. The patient has to do that. But volume support is for the patient that we can set the tidal volume, and I no longer have to go in and out of the room and adjust the pressure support level. I'll tell you an example of this. A long time ago, if we had a patient in pressure support, Dr. Simpkins might say, Ryan, he really likes 350. When the patient's tidal volume gets less than 350, he wears out. He gets tired, gets tachypneic. So Dr. Simpkins says, Ryan, I want you to keep my pressure support at a level where my tidal volume stays above 350. And he used to write that order. Well, he didn't, he wasn't here then, but we would go up and down on the pressure support to do the same thing as I talked about earlier, to keep that patient's spontaneous breaths in a range that kept them from wearing out. Volume support fixed that problem for us as well. We can now dial in 350 or 400, wherever that point is that we think is enough support for them, that they don't wear out. And when the patient starts the breath, it's going to go up and down on the pressure support to give them that size tidal volume. That's the key though, it's a support mode. So your patient has to initiate every breath. There's no rate in this mode. So if they get a bolus of some sort of sedative or morphine or something, then you need to be watching that vent, watching that rate. So it is a support mode, so the patient has to initiate every breath. So volume support is to pressure support as PRVC was to pressure control. It kept us from going out of the room to adjust the pressure support mode. Can they be paralyzed and sedated in this mode though? No.
Yeah.
What's the disadvantage of this? They're fully awake.
They'll
They'll fight it. Very good. So what you can do, if they're fighting this, flip them over this with the same volume, and they'll get the same volume and see how they fly. If they do fine, keep them in volume support. But if they get tachypnic and start breathing higher than 30, 35 times a minute and they're wearing out, then we have a decision to make. We either have to knock them back out and put them back in PRVC, or we can go to a mode that we'll talk about in a minute. So volume support. So kind of state something back to me that you understand about volume support. What's an advantage of it? And,
patient controlled.
all right, patient control. The patient controls their eye time, their respiratory rate, and they start every breath. What's nice that the vent does for them at that point?
Gives them the most volume. Pressure.
Gives them the pressure to get them the volume they want. Very good. And how come? What makes it better than PRVC? And she already said it.
It's not controlled. I mean,
Yeah.
you're not controlling it. They are.
Yes, I can breathe like, if I'm on volume support, I can breathe like this. Or I can go, I can stop for 5-10 seconds. I can breathe again. It's not waiting on me to take a breath and just shove something in me when I don't want it. It's just gonna wait, it's letting me do all the work, except it's gonna help me with that tidal volume. It's basically gonna supplement me with that tidal volume. So that's volume support. Do you have any patients on volume support today? Any of your patients at all? If you do, you can tell how much work the patient is doing versus the vent. For example, I'm just going to draw this out. If the patient is on, let me draw this out. If the patient is on 5 a peak, and let's say that your peak pressures are 20, what is my delta peak? What's my pressure difference between the breath? From the pip down to the peak, what's the difference there between the pressure? So it's taking 15 of pressure support to help this patient right now in volume support. You walk to your next patient. By the way, respiratory rate's 18, tidal volume's good. Of course, it's set. SAT's good. Blood gases are good. You walk to the next patient's room. Their peak pressures are PEEP's 5. Their peak pressure's 10. So we've got a difference of what? If this is 10 and this is 5, what's my difference there? So they're on 5 of pressure support. Who's closer to being extubated?
5.
The 5. The vent is doing the least amount of work. The patient's doing all the work here. Over here, the vent's doing most of the work. Does that make sense? Same mode, same rate, same blood gas. But I can look at the difference between the PIP and the PEEP to see how much work the patient versus the vent is doing. If this peak is 35 and my PEEP is 5, well, I know if I extubate them, well, they're not going to fly. They're on 30 of pressure support or 25 of pressure support. Does that make sense? And the minimal amount of support that you want to see a patient getting is 5. Anything more than that, you're going to be working them out. But that's how you can look and see, is the vent doing the work or is the patient doing the work? So that's volume support in a nutshell. Does that help any with volume support? You'll see it on the 300s and you'll see it on the eyes.
There's a readout for the work?
There's not a readout for the work, but there's a readout. You can see the peak pressure and the PEEP. So you can just subtract the two. That's all you have to do. By the way, we're getting, these modes are also on the servo eyes. We're buying 10 more of those also.
That is awesome.
So we're getting 10 more of those.
That is outstanding.
So we'll have those on hand pretty soon. One last term to talk about, then we'll talk about bi-level and APRV. One term you need to know is mean airway pressure, because anytime someone brings a blood gas back to you and you don't know what to do to help the patient oxygenate better, it is to increase the mean airway pressure. That's how you fix patients with low PO2s. For example, you're on call tonight, your patient's already on 100% oxygen. You can't go up on that, can you? And here's the gas, comes back, I'm just going to tell you the PO2 on it is 45 on 100%. But you know it should be about 600 or 550. So that's pretty bad shunt going on there, so we got issues. So what are we going to do? We can't go up on the oxygen, can we? But what we need to increase is we need to increase mean airway pressure. And I'm going to define that for you. Mean airway pressure is the surface area underneath the pressure waveform. And it includes any area under the waveform from the start of this breath to the beginning of the next breath. So, you don't even have to know the terms on the vent because it doesn't matter. It depends on the flavor vent you have on that bedside. But you can still talk to the therapist about what they need to do. What can I do to the shape of this waveform to get more surface area under it? What are some options?
You can make it longer.
Good, I can make it longer. So, depending on what flavor vent that is, that would possibly be eye time. Y'all agree with her? I can increase eye time. So that's one option. I can increase eye time. Very popular. I love to increase eye time for mean airway pressure. It's my favorite, actually. One of my favorites. All right, good. So that's one option. What else can we do to the shape of this waveform to increase surface area underneath it? All right, good. She says, she's a scholar up here. She says we can increase the pressure, or if I'm in a volume mode, that would be increasing the tidal volume also, right? So I can increase pressure or increase tidal volume. When would I be scared to do that? When would be my concern, especially if Dr. Simpkins is around? If I see that wood is already at a certain level, when would I fear doing that? If your peaks are already 30, 35, you might not want to go there with that one. You might want to try the eye time first. Eye time gives you a twofold benefit. I'll tell you this. If you increase the eye time, you're increasing the time the ventilator has to give a certain breath. If you do that, you actually bring the flow down. So you might actually bring your peak pressure down by increasing the eye time most of the time. So, so it depends on what flavor vent you're on. You can increase the eye time. I should wrote this out here, or you can decrease the flow. That's a little flow symbol there. So you can decrease the flow. So those are some choices. What else can I do to this? There's one last setting that we, as therapists, usually call and ask for first. If their SAT is low, we want to go up on some other setting that gives them pressure all the time, even on expiration. And it's a positive end expiratory pressure. PEEP, very good. So if I were to draw over this and I said, okay, let me give them 5. And now what I have is I have a new baseline, and I'm giving the breath on top of that. You with me on that? See what I've gained? And remember I told you the definition is from the beginning of one breath to the beginning of the next. So you gain this as well with PEEP. That's why PEEP is the greatest contributor to mean airway pressure out of all these factors. So I can increase PEEP. That's a popular one. We like to increase PEEP a lot for oxygenation. Now remember from slide 1 though, anytime I'm changing these, yeah, you'll think I'm lying to you if you change it and it doesn't work. But anytime I add pressure in the chest, what do I need to reconsider? From the very first slide we talked about.
That you're pressing on the heart.
Pressing on the heart. So what do I need to reevaluate every time I increase this pressure?
Cardiac output.
Good. I need to assess cardiac output, either by cap refill, blood pressure. If they have a swan in, you can look at that. You can see if their SVO2 is dropping. Then you're impairing delivery. So what would you do if the therapist is saying we need more PEEP, and they can look at the ventilator and see the compliance is getting better with more PEEP, but every time you go up on the PEEP, the blood pressure drops, heart rate's going up, and the SAT even drops. How can we fix that when the therapist says, look, the compliance is better, meaning the lung likes it. You know, the stretch of the lung is easier now that we have PEEP. But according to the vital signs, we're killing the patient. What can we do to fix that that end of it? Because here's what I'm doing. I'm giving this patient a generous amount of PEEP that I'm opening lung up, but I'm starting off with a wimpy pulmonary capillary because I'm just a little dry, aren't I? So what do I need to do for the patient? Yeah, as much as you hate to say it, you can try a little challenge of fluid, and when you do, you give a little more turgor to that vessel so that this generous amount of pressure here isn't stepping on it. Instead, now you reinflate, for lack of better terms, the vessel so that you get some Q to your V. And that's where our VQ goes wrong a lot of time in vent management. Is I'm telling you, hey, I'm going to open this patient up, but then we get gun shy because blood pressure drops. Well, is it dropping because it's too much PEEP, or is it dropping because they don't have enough fluid to begin with? Well, if the lung is saying yes and compliance is getting better, it's because they don't have enough fluid to begin with. And when you push that, then we can match that up and get away with having V and Q matched a lot better. So do you see how I determined though they need Q and not less of that? Because we could bring the V down. I could come back down the PEEP and say, Doc, all right, man, I'll come back down. And I come down, X-ray stays crappy, SAT stay crappy, and blood pressure's fair. And then 6 hours later, urine output drops because they're drying out and now their kidneys are failing. No, I'm just kidding. That won't happen. But still, that's when you need to know the difference between the patient doesn't like it versus they just need more Q. Are you with me on that? That's what makes a difference at a bedside of us being able to fix the patient. Is us talking with y'all and the nurses and figuring out, is it a V problem or is it a Q problem? So, anytime you make these changes, you need to reassess Q, because it's going to impair pulmonary blood flow to a certain degree, especially on your sickest patients. So I'm not here to tell you that cranking up PEEP and all that fixes everybody. Some patients can't handle it, and for that reason, if they don't get fluid, they're definitely not going to be able to handle it. So, but your therapist will usually be able to tell you if they need more or less PEEP, because they can look at compliance. And when the lung becomes so sick that all we're trying to do is oxygenate them, we do a lot of times do permissive hypercapnia, at least on 7th floor. I think sometimes in SI we do when they get so sick, don't we, Dr. Simpkins? They get so sick that there are times when a therapist might come to you and say, look, we might have to pick which one is more important to you right now. You know, you got someone with Swiss cheese lungs already. Do you want CO2 to be fixed, or do you want PO2 to be fixed? And if the lung is truly that sick, your goal is PO2. CO2 has never killed anybody. The pH has, but the CO2 doesn't kill anybody. So we can instead, all right, that's a good little ringtone there. And the CO2 does not kill you, it's the pH that does. Now hypoxia will kill anybody, won't it?
Oh, yeah.
So I would chase that and leave the CO2 alone if it becomes an issue. Now, what makes trauma interesting is y'all are dealing with head injury patients. So there's a window that you have where you have to have both. You know, you feel you need to have both for a while. So that's the challenge of trauma. Another challenge of trauma is from slide 1. Is what did I tell you that I visualize? When the patient's laying there and they're on the ventilator, I told you that I visualize what's wrapped around their neck and their belly.
Rubber band.
A rubber band. So if I put a lot of pressure in the chest and I'm trying to fix your patient's PO2 for you, what am I doing to the venous return from the brain? If I'm cranking up pressure in your chest, I'm decreasing it. So you have that to contend with too. So y'all have a fun job with us, you know, in thinking, okay, we want to open the lung. Ryan, open the lung. Ryan, open the lung. Next thing you know, we herniate. You know, didn't do any good that we opened the lung because he doesn't know anymore. And so that is the challenge in trauma, is to say, okay, this mean airway pressure and this mechanical ventilator does a lot more than just breathe for us. It does affect a lot of other parameters. So keep that in mind. One last mode I want to cover real quick and let you know why it's popular, why we use it, and how it's used in different places. It's called bi-level or APRV or bi-vent. Depends on which flavor vent you're on. This typically means that you're using short E times and causing air trapping. It stands for airway pressure release ventilation. These two flavors are just, this is on the servo, and this is on the PV840. So, not that you have to know that, but that's just the two different vents call it different things, but it's the same technology. What bi-level allows you to do is it allows your patient to breathe at any time during any part of the breath cycle, and I'll tell you why that's important. Do you remember our patient a minute ago that's in PRVC? And you told me that it was uncomfortable, because I told you it was uncomfortable, and the patient would fight it. Well, if they fight it, I'll go back 2 slides. If they fight PRVC, and you decide, well, let's just wake them up like Ryan said and go to volume support. Well, when you wake them up and go to volume support, they breathe 35 times a minute and they desat. Well, it's because they lose this. And what's the definition of that? What's the definition of the surface area underneath that pressure waveform?
Yeah.
That's the mean. See, what they did is you woke them up and look how they're breathing. See, no mean. See that? Not a whole lot of mean, is it? So they lose that, so they desat. So you say, well, let's just knock them back out and put them back on PRVC. Well, every time you give them a sedative or a paralytic, their blood pressure hits the floor. Y'all probably seen that before. And you're like, well, crap, what's the best thing to do? You have an option to allow them to be just sedated and not paralyzed and breathe over on APRV and bi-level, and I'll show you why. If they cough right here on PRVC, if they cough or fight it, it actually pressure limits and cycles off. The vent breath is terminated. So look what they lose. They lose all that mean. So they'll desat even if you keep them awake in PRVC. But watch, if I put them if I put them over in bi-level mode, the mode allows the valve to float. I went the wrong way. The mode allows the valve to float, so that when the patient breathes over or coughs right here, if he coughed right there in the middle of that breath, that valve will lift and open. And then when he sucks back in, the valve will close and give him flow. So he can basically breathe he can breathe in and out. and I'm going to try to do an impression in case that camera's on me right now. Here's what it looks like. The vent inflates the lung, and the patient goes, and then they exhale. They can breathe in and out during any part of the respiratory cycle. Does that make sense? I'm still pressurized, and now I'm just breathing in and out. That valve is floating. It's no longer locking me out. So the patient can breathe in and out at this point, at any point they want. So no longer will the vent alarm and cycle off. So look, we don't lose all that mean. So bi-level, bi-vent APRV allows you to keep your mean and let the patient breathe over. And the beauty of letting the patient breathe over is that they're going to fix their CO2. Does that make sense? If you're conscious and not paralyzed, your chemoreceptor is going to tell your brain you need to breathe and fix your CO2. So when I wake you up and you breathe, you fix your CO2. So I don't even have to worry about rate. I'll let you fix your CO2 to a certain degree. You'll help me with it. All I have to concentrate on then is your PO2, and I just play with your eye time to fix that. So your patient can breathe in and out anytime they want during bi-level or bi-vent. APRV though, Dr. Simpkins uses APRV like the literature explains it. APRV is still using the technology, letting the patient breathe over when they want. You get a long eye time, but APRV is such a short E time that, watch this, it doesn't even come back down to 0 before the next breath is given. So what we have is we intentionally cause air trapping. And the theory is that if you don't let flow stop, listen to this. If you don't let flow stop, I'm going to try to draw y'all a picture here. The theory is, if this were indicative, or I guess an example of 3 different sections of your lung, this might be the normal. This might be the normal part. This might be the overinflated part. This is the collapsed part. The theory of APRV is that if you pressurize to say 30, let's say this is 30, that you've opened all these. Okay, we pressurized to 30, so these are all open. If I don't let exhalation completely finish, if I don't let flow completely stop, then this will never collapse again. That's the theory. Are y'all with me on that? This will never collapse again if I don't let flow go all the way out. Because this one and this one are going to collapse first. Won't you agree? Because that's more volume. So these are going to shut down first. But if I don't let flow stop and I put another breath in before flow stops, those never collapse. And that's the theory of APRV. And that's what Dr. Simpkins does. He does the true APRV according to literature by having a short E time so that when they exhale, flow does not stop so that this does not collapse. And all we do is we cause intrinsic PEEP. And we can measure that if the patient's paralyzed. We can measure and give you an idea how much intrinsic PEEP is there. But it really doesn't matter what their intrinsic PEEP is because we're controlling pressure. They're never going to get more than what their high setting is. So APRV allows the patient to breathe anytime they want, but it does so in a manner that we don't let them finish exhaling. We actually don't even set a low PEEP until we start weaning them usually. We then set their PEEP at that point. Or you can do it like the picture first showed, where they come down to a PEEP that we feel, we might set a PEEP at 5 or something, somewhere where we think they need some PEEP, and so it can be managed that way as well. But in SI, it's typically managed where you cause air trapping on purpose for that reason. So tell me the advantage of APRV. Why would you move to it? When would you suggest it? Because I mean, we have PRVC, we got SIMV, we got volume support, we got pressure support. Why would I go to this when I have all those other choices? What does this allow your patient to do?
It allows the patient to breathe on their own. It's comfortable.
Okay.
Control their CO2.
Good. The patient can breathe on their own. I'm not going to necessarily agree on comfortable, but they're not fighting it. They will breathe over. They still have to be heavily sedated because it's like me taking you and putting you on 30 a PEEP, and then you trying to breathe. You know how I was doing a minute ago. So I don't want to remember that. So I probably need to be sedated. But it does. It allows me to breathe and allows the patient, because they're breathing, allows them to control their CO2. And from slide number 1, what's a good thing about them spontaneously breathing? What else might they contribute? Cardiac output and venous return. I mean, that's a key. So we can get rid of some of those things that are against us to begin with. And with APRV, though, as Dr. Simpkins manages it, short E time so that you cause some air trapping. Whereas these modes, if we use them typically on 7th floor, we'll allow them to come down, but we're very generous with their low PEEP. So we achieve the same thing, but we just have a known PEEP instead of having a trapped PEEP at that point. So which patient would get that? I call you in the middle of the night and I say, Dr. Whitlock, I think our patient needs to be on bi-level or APRV or bi-vent. What might I see the patient doing that I decide they need that? Because not everybody gets it. What was that example I gave you? They were fighting PRVC, but why don't I just knock them back out?
Well, because they're not getting enough mean airway pressure, breathing on their own volume support.
Okay, good. But why don't I put them back in PRVC and just knock them out? That way I can give them back that mean. Why can't I do that? What might happen to them? What vital sign is affected sometimes when I
With
give
the
them?
blood pressure.
Yeah, like if they don't tolerate that paralytic, or your CO2s are getting uncontrollably high. Those are two reasons to go right to this mode. This should be taking mode of high frequency. If you think about it, Dr. Simpkins, I want you to take note of this.
Mm-hmm.
If you look at this pattern that I'm drawing,
Mm-hmm. I see it's like a high frequency.
it's just like an oscillator.
Mm.
That's what oscillator does. The oscillator goes to a mean, holds it at 30, and it pants for the patient around it. Well, this mode allows you to go to 30, let the patient pant for you, and fix their CO2. So if you have a CO2 issue with a patient who is in PRVC and you got their rate crazy high, I would move to this, and that way it's a win-win. You can definitely get their PO2 fixed because you got all this mean, and let them fix their CO2. So the more we use it, the less we're gonna use oscillators, I think, because oscillator, instead of having this dump right here, oscillator doesn't have to have a dump because it breathes so fast. It breathes 600 times a minute that CO2 is not an issue. Whereas this, if they're breathing 60 times a minute, we're still going to have a dump so that we can get an expiration, if you will, of CO2 so they can clear that. And so, so bi-level and bi-vent and APRV, if the patient's awake, they're truly going to mimic oscillator ventilation more than any other mode. And that's what we go to it. And not that you think of that the very next time someone calls you, but at least you know why a patient might be on bi-vent or APRV and bi-level. And I know Dr. Simpkins has probably been doing some reading. This mode here is used, and I've heard you say this at the bedside and actually had to defend you. Someone said, he said he wants to use it prophylactically. And you know what?